discussion session for AF ablation. Again, we have quite a few questions to get through, and particularly one of the big topics, certainly in the UK, is catheter ablation for patients. Atrial fibrillation, of course, is a very common condition. There's about 1 million people in the UK with AF. We can probably only ablate about 5,000 of those patients. So the question has to be which patients for catheter ablation. I guess if Dr. O'Neill, perhaps you might like to kick off this session. Should ablation be the first-line therapy for paroxysmal AF?
No.
That was very succinct.
I think if the question was, could ablation be the first-line therapy for paroxysmal AF, the answer would be yes. But should it be first-line therapy? I don't think for everybody with atrial fibrillation as a new diagnosis for paroxysmal atrial fibrillation that the first-line therapy is ablation. Ablation is clearly better than antiarrhythmic drugs, but again, I would go back to the point I made earlier about patient selection, and it's something that we'll come on to. Patients may choose to not want to have an aggressive procedure as the first-line treatment for a condition about which they really know very little when they come to you the first time. But I think that there are patients, and we've all met them, who come to see you and say, I really don't like having these palpitations, I really don't want to take drugs, tell me about the other options. You explain them, they go, yes, I want to have that. And in that situation, I would say that catheter ablation as a first-line treatment is perfectly reasonable.
Can I ask what you would have if you had atrial fibrillation?
Drugs.
What about everyone else?
I wouldn't go with drugs. No, I would select one of the key ablation sites over Europe, one of you guys here, and share my problem with you, and I would go for ablation. I think you put it in clinically in very, very meaningful and useful words. It's the preference of the patient. The patient needs to be informed about the expected course he's going to take with his atrial fibrillation, the different treatment options. Symptomatic patients with atrial fibrillation deserve rhythm control strategies. As first-line therapy, drugs are a good solution for selected patients, and that is, again, to me, beautifully outlined in the ESC guidelines. For selected patients, catheter ablation may be a good solution for first-line therapy as well. What are selected patients? Highly symptomatic, low-risk profile for ablation. So the young and healthy ones, a little bit of arterial hypertension, not obese, no risk factors, as good as we can project it for interventions. For these patients, first-line treatment, yes. As a general rule, I would say no.
Gareth or Mark, so when you discuss with your patient the efficacy of your catheter ablation, what is the number that you are giving to the patients at which is the time frame they're talking about? So are you promising the curative therapy for lifelong, or you say, well, it is 50% in my hands, Dr. Hendricks says 70%, and I mean, Dr. Lambiase maybe 90%, and if you like to have a 90%, go to Dr. Lambiase lab, or if you accept the 50%, I can do that. So how you make the decision also with the patient, but more obviously also with the referring cardiologist?
It's a very important question. I think you've used a word that I never use with patients, and that's promise. I think it's very important with any therapy. And I was trying to think of one while you were speaking, with perhaps the exception of AV node ablation, where you can promise that what you do is going to be 100% what you set out to do. So I think that with atrial fibrillation ablation, we have not been doing it long enough to have meaningful data for patients who are in their 40s and 50s. Remember, this is a technology which, an approach to treatment which really only took off in earnest in the early 2000s, and which we feel we've got a handle on in perhaps the last 5 or 6 years. So the patients that we are treating are patients in their mid-50s, largely in the clinical, in the published data. And what I say to a patient is, you're 50. If you're going to ask me what am I going to be like in 20 years' time, I cannot give you the answer to that. I can tell you what you're going to be like in 5 years' time based on published data. But I cannot tell you anything more than that. But I equally can't tell you anything more than that with antiarrhythmic drugs for the sort of time frame that we're talking about in these young patients that we're treating.
So which is the most common number that you're giving? I mean, for paroxysmal, for permanent, persistent?
So again, I think it's really important that we move away from dichotomizing atrial fibrillation into these three groups of paroxysmal, persistent, and permanent. There's new data coming out over the course of the last couple of years looking at comorbidities in a small way, and now some really interesting data coming out on the association of the CHAD score with outcome following a catheter ablation, and newer data coming out on substrate assessment, for want of a better word, such that atrial fibrillation is no longer seen as 1, 2, 3, you're in that category, or that category. So I would say, like Gerhard has said, to a young patient with a CHAD2 VASC of 0 or 1, that I would expect, if they have paroxysmal, highly symptomatic atrial fibrillation, that there's a very high likelihood that they will be improved by a catheter ablation procedure. Now, by improved, that may mean complete elimination, but improved, I would say, up to 90%, there will be an improvement in the way they are. If you're talking about complete cure, then I think that's very difficult to say for an individual patient. I think it's not unreasonable to say that it's likely to be higher than 60%.
Okay. At 1 year, 2 years, 3 years?
And I think those are the only kinds of numbers that we can meaningfully give, because we do not have long-term data.
This is after one procedure or multiple procedures?
After one procedure.
So one procedure, you say 1 year is 60?
I would expect to be able to achieve in that kind of patient somewhere between 65-75% with one procedure.
So you have a better goal in hand?
No, that's a very realistic figure that Mark has put on the table. And I completely agree with everything that he said. In medicine, we should be very careful with guaranteeing something or promising something. I always tell my patients I can guarantee that we give our best to help you and to bring you safely through the procedure. But that's then guarantee stops, and we have to look to the figures that we have based on the treatment results. And our results in Leipzig are, as I think that's good for everybody sitting on the table, comparable to Mark's results. It's between 60 and 70% in patients with the low CHADS VASC score. These are low risk patients for the intervention with paroxysmal atrial fibrillation, single procedure. If you do multiple procedure, and I always tell my patients that there is at least a likelihood of 20-25% that we will meet again in the cath lab to close gaps in case of relapse or to treat left atrial microenterant tachycardia. For multiple procedure, you can end up with 80+X% freedom from atrial fibrillation or highly significant improvement, which is a reasonable treatment goal as well, over time period 2 to 3 years.
Well, personally, I think this kind of numbers, again, going back to the very first part of this meeting, when we have to be very open and frank and honest with the referral cardiologist, I think that would be good to have this kind of a numbers somewhere where you can probably provide different scenarios where they can help the people orienting themselves, because again, making expectation or giving too much expectation to patients and to physicians may create a sort of distortion in terms of what they, at the end of the day, they do get back, and they do get back usually the uncured or the patients who still complain of symptoms, and this creates a sort of, I would say, bad attitude around all non-pharmacological therapies in general, because, you know, drugs is expected that you fail the drug and you move to the next. It's easy to switch from one to the other one. But for the non-pharmacological one, this is something, again, when you say, well, I have to do something better than I have done. Hein?
Yeah, I wanted to add one thing. Something which I miss often in addressing AF is a mechanistic classification of the AF. Mark alluded to the fact there is not just 3 types of AF, and to the fact that the CHADS score is related to the outcome of an AF ablation. And I think, in fact, that relates much to what is the mechanism of the AF. And we don't look at that very often in the clinic, and I think we miss an opportunity there. I think where we can prove that the AF is really triggered from the pulmonary veins, what we tend to call focally induced atrial fibrillation, there I think we can tell the patient that we have a very good chance, because that's a substrate that we can address very well. Our techniques are very well developed to do that. And so I think we have to look for that. And the Holter is a simple tool. And if there's a lot of atrial ectopic beats with short coupling, then we know these must be coming out of the pulmonary veins, and that is something we can address. And that, of course, will overlap with chats and scores and with the risk profile, as you mentioned, Gert. But I think it really focuses more on the substrate and the mechanism itself. That was addressed in one of the latest consensus documents by ERA and AFNet, this mechanistic classification. We acknowledge that there is not enough science yet, but I think we have to move more into that direction to understand what's going on. If at the other side of the spectrum the whole atrium is diseased, which typically presents itself by long-standing permanent AF, very small fibrillation waves on the ECG, dilated atrium and so on, then we know that what we can do is very, very limited, and probably that is not the candidate. But this brings us back to the mechanism and not just to a phenomenological classification.
I mean, very often a term we use is sort of a AF patient journey, so when the patient comes to see you, you give them a horizon well beyond the first procedure, so what they can expect, both in terms of the procedures and also the medications they're going to need to take. And I think very often the first time the patient comes to see you, they think you're going to just do one procedure or give them one tablet and then it's all over. And it's such a complex disease that actually the resources you need, not only in your 20 minutes, half an hour in the clinic, you need considerable support to manage these patients through these procedures.
Importantly, referring physicians also think that it's a one-stop procedure, just like AVNRT or accessory pathway ablation, and they don't realise when a patient comes back, they see that as a real failure of the therapy, whereas in fact we fully expect to see that in up to a quarter of the patients.
Can I just say, though, I think we're being all a bit pessimistic and depressing about it, because actually the young patients with low Chas vascular and no other comorbidities, I think that we'd achieve a much higher, I'd be very disappointed if we didn't achieve a 90 to 95% success rate after multiple procedures off drugs. I mean, it's very unusual to see those patients coming back with recurrent AF after you've isolated all of their veins permanently. And they do very well. They don't come back to our clinics. You now have thousands of patients going through Leipzig, and you know that you're not seeing them coming back 5 or 6 years later, and their lives are transformed. I mean, they're absolutely transformed. And I don't think we're making it all very dry and data-driven, but the reality is that you are transforming patients' lives.
But I think this is really the challenge, to identify the patients who really do best. Because, this is really the one who are really, at the end of the day, who are really grateful to referring physicians as well as to you. And as you said, we have not been able to understand or to make well enough the patient selection. And because, at the end of the day, this becomes to an individual conversation with the patient. So as you say, if age and the kind of mechanistic approach, so single atrial extrasystoles is the trigger mechanism, and you can say, well, you know what, I believe that we can make this one, and we can, or very likely you are going to be for the next 1, 2 or 3 or 5 years, freedom of symptoms of arrhythmias. That is something that is very reassuring around the therapy and the way in which we also presenting and the therapy to the patients and to referring physicians. So this is where we are still missing again this kind of patient or segmenting our patients' population of refer to patient population to give the good numbers to the people.
But it becomes clear that the earlier you start with this treatment, it's better. And it takes time to prove it, to show from retrospective analysis. And you have to remember also that the technique is developing continuously. And as Mark said, the last 5 years, I would say we are happy that we understand much more. And we have strategy that we apply, at least in paroxysmal atrial fibrillation, in all patients, and from some retrospective analysis of our data, it comes that those patients who are young and without any structural heart disease, the success rate is really going to 90%. But I think we need more time to prove it, that it's safe, efficacious, and the earlier we start the treatment, the better for the patient.
I agree, but but sometimes that is interpreted as being when we intervene earlier, we prevent things from developing over time. I'm not so sure about that. I think we have a larger window where we can make a difference for the patient, because what we do early is isolate the pulmonary veins, and that's where usually the problem starts. But we know now from series with longer term follow-up that there's a gradual picking up of atrial fibrillation later on, which is not so unexpected because we know there is also atrial disease developing, and maybe the underlying reasons are the same. Just the mechanism first expressed itself via the pulmonary veins, and later it expresses it via the atrium. So I think maybe we have a larger window. I'm not convinced yet that we will really change the natural history of all the AF patients. Maybe.
The fact is that if they come back, you always realize that they have some gaps in conduction lines.
Sure, and then we cure
in isolation lines, and that's a problem, that you are not sure, is it progression of disease, or is it some reconnection, or is it just because our initial strategy was not good enough, because there are some gaps in these isolated areas, and the patient can in time develop again.
That's true, but there's also patients without gaps that still develop atrial fibrillation, so it must be somewhere else in the atrium. And that's why I think diagnosing atrial fibrillation must be a moment where we reflect on why does this patient of 55 years old develop atrial fibrillation now? What has happened the last 55 years? And what will still play a role in developing an atrial substrate for AF in the upcoming years? And how can we modify that? And that modification is not just by rhythm intervention and ablating the pulmonary veins maybe, but there may be more work to do. We all know we have to treat hypertension, we have to tell the patient he should work on his overweight, and so on and so on. I think it's a moment of opportunity in a broader sense than just a rhythm therapy.
But the question that people watching this video will be asking is, who should we refer for AF ablation? And to my mind, that seems pretty clear that number one, they have to be symptomatic. Number two, if they have paroxysmal AF, they either have to have failed drugs or not be prepared to take antiarrhythmic drugs. And number three, if they have persistent AF, they have to have had AF for less than 3 years. And that's interesting that because most of the big centres are now shrinking that timeline. So it used to be, it's got to be less than 5 years, now it's getting less than 3 years, and people are getting more fussy about who they want to take on for persistent AF ablation. Is that fair?
What do you think of left atrial size? Do you think that should come into play?
Well, I think it correlates so closely with the length of time that people have been in AF for. It's easier to measure how long they've been in AF than the left atrial size.
I think it would be much better to see what is really composition of the myocardium and wall rather than size. There is no cutoff for size. There is some proportion with success, but
we see a very interesting increment of for every half centimetre in LA size, you get a degradation in the efficacy of ablation, long-term efficacy. So it's quite remarkable how such a simple parameter.
But for a referrer, it's much easier to ask the patient how long they've had AF for.
Absolutely, absolutely. Yeah.
I think we will see steps towards individualized substrate analysis and decision making in the future that will make our lives easier. There is a correlation between all the parameters that have been discussed here. I personally believe that imaging will play a role in the future, fibrosis, visualization of scars on the atrial level, and that there are initial data indicating that correlates with the options that we have to successfully perform catheter ablation. The more advanced the disease is, the more fibrosis and scar we have, the less good the outcome is. And I see a certain limit that needs to be defined by studies. Once that has passed, other strategies and not catheter ablation may be more adequate.
You know, I'm wondering, because we are talking about scar imaging. I mean, we have tried several times to reproduce what some other labs overseas have been nicely published, and we failed we failed, and again, I was always blaming my radiologists, my colleagues in cardiac imaging, say, why you're not able to show me this beautiful patchy area of fibrosis. I'm wondering about your experience. I mean, sorry, Mark, I stopped you before, but
I had completely different topics, so
I have exactly the same experience, and I discussed last week with Jeroen Baks from Leiden exactly the same experience. So we are a bit skeptical about, at this moment, about the use of this particular technology for assessment of substrate and changes in substrate. So I believe that there might be some technique that will tell us, but at the moment we don't have the technique, and I am very skeptical about the data that are published.
I would just to come back to what Richard was saying earlier. I mean, this time frame for persistent atrial fibrillation, some of these patients do very well with ablation, and the time frame for effective ablation is coming down. But again, for the people watching this video, time passes very quickly. So if we're saying 2 years is the cutoff, by the time potentially a general practitioner first sees a patient with a 6-month history of palpitations or a 9-month history of palpitations, sends them for an echocardiogram, which may take 2 or 3 months to get, and an outpatient Holter monitor, gets the results back, looks at them, a year and a half could already have passed by the time that patient actually gets referred to an electrophysiologist for assessment. And it does take us right back to what we were discussing earlier on about the referral pathway. Really, for these kinds of patients, perhaps less so for the paroxysmal patients, but for the persistent patients, if that time window is shrinking, we really do need to be in early to detect those patients, and they need to be referred very early in the course of their disease.
I'm doing a commentary on the MRI data. We've just submitted an interesting study where we asked our MRI specialists to identify whether the patient had their ablation or not. So they had a pre and a post-ablation MR, and then we asked them to tell us which was which. And they did pretty well. They were about able to predict which was which in about 84% of cases. But that's the level of lesion imaging that you're seeing. It's still difficult for them to even tell whether the patient's had an ablation or not.
Yeah, that's congruent with our experience as well. I mean, if we look to the data which have been reported mainly from one US center, we at least have to leave a very, very small rim open for the fact that they can do better than we do. They shouldn't be smarter than we are. I would exclude that, but maybe they can do better. We need to see technological and technical improvements in the MRI field in order to make this technique, if it works, accessible to everybody. The Utah group has to open up their black box and algorithms, how they do it. They promise to do so. The multi-center international study data inclusion has been completed. We will see the data. We will see the data in a couple months, and that will shed a little bit more light into the role of the technology in the future. I personally believe that since we, in principle, can visualize scars with MRI, that with further technological improvement, it will be possible. But I share my doubts with you that we cannot do it on a very reliable basis right now.
I still want to know what everyone else would have. If you had a symptomatic paroxysmal AF, would you have drugs or ablation?
Are you going to give us a window of how frequently we have atrial fibrillation?
So it's interfering with your life enough to want to take a therapy?
I think if it was seriously interfering with my quality of life, I would go for ablation first. Yeah.